Nah, it's okay. So I don't think I've given this lecture for the residents in quite a while, though some of you have seen a version of it as medical students, but I promise you, even those, there's going to be some new stuff in here. So I'm going to talk today about toxidromes, and toxidrome is short for toxic syndrome. And remember, a syndrome is a cluster of clinical signs and symptoms. So you do not need to send any esoteric tests at the house, but you don't need the brain biopsy or the MRI. It's all from talking to the patient and examining the patient. Another critical aspect is that you don't have to know what the person took. By identifying the toxidrome, you can figure out what class of medications the person took, and if that is enough to know how to treat them without knowing what they actually took. So it all starts with the toxicologic physical exam. Well, it actually all starts with the history, but a lot of the time these patients won't be able to give you a history. And the toxicologic physical exam, we focus on a full set of vital signs, which in this day and age should include a finger stick, glucose, and pulse oximetry, mental status, and a lot of people will say altered mental status, and I hate that term because it doesn't distinguish between the person who's wildly agitated and the person who's comatose, which suggests very different kinds of toxidromes. So we try to be a little bit more specific about the type of alteration in mental status that you're seeing. Pupils, are they dilated, are they constricted, are they reactive or not? GI motility, anybody know what this is?
Megacolon.
Yeah, Megacolon in the Mutter Museum of Medical Curiosities in Philly. If you're ever there, definitely go check out that museum. So are valve sounds present or absent? Are they increased, decreased? GU function, are there signs of urinary retention? And then skin, mucous membranes, axilla, is it warm, is it dry, is it flush? Those are all things that you're going to want to be looking for. So the basic toxidromes that most people talk about are cholinergic, anticholinergic, adjuncts, which some people call sympathomimetic, sedative, hypnotic, and opioid. And I'm going to introduce each of these with a case. These are all real cases from when I was a fellow at New York City Poison Control. And at the end, if we have time, we'll go through some little more challenging cases and see if you can identify the toxidrome. All right, so first one, 38-year-old male firefighter responds to the scene of a helicopter crash in southeastern Missouri. He comes to the hospital, he's vomiting, he's got blurry vision, weakness, and trouble breathing. And these are his initial vital signs. He's bradycardic and tachypnic, he's hypoxemic, and he's in obvious respiratory distress, he's diaphoretic, he's puking, and his pupils are small, he's got a lot of tears and oral secretions, and he's got diffuse bilateral wheeze. Cholinergic, excellent. All right, so this helicopter had been spraying crops with malathion, but you don't have to know that. You just have to identify that this is cholinergic. So there's a lot of cholinergics out there, whether it's pesticides, whether it's military nerve agents, some of the things we use medically, like physostigmine, or this is the calibarbine from which physostigmine is derived, or edrophonium. In order to understand what happens when you're poisoned with a cholinergic agent, you have to understand normal cholinergic function. So this is a generic cholinergic synapse. And when an impulse comes down a neuron, that's a cholinergic neuron, it releases acetylcholine into the synapse. The acetylcholine binds to the postsynaptic receptor. It causes depolarization in the target organ, and then that leads to some kind of target event. And what the event that is depends on what tissue that's in. In that synapse lives an enzyme called cholinesterase, and this is actually the most active enzyme in the body. It has to be when you remember that acetylcholine is the neurotransmitter at your neuromuscular junction. So when you think about when a movement has to be able to start and stop instantly, and that happens because you're able to instantly break down any acetylcholine that gets released. So cholinesterase has two active sites. One positions the acetylcholine into place, and the other breaks the ester bond and leaves you with choline and acetic acid. Choline gets taken back up into the presynaptic neuron, acetic acid goes off into the Krebs cycle or something, and you stop stimulating your postsynaptic receptor, your target organ repolarizes, and the event stops. So when you have something that sits in the active site and binds to the cholinesterase, it basically, through steric inhibition, prevents the cholinesterase from getting at the acetylcholine and breaking it down. And when that happens, you get more and more acetylcholine in the synapse, more and more stimulation of the target organ, and more clinical effect. Now there's two types of cholinesterase inhibitors. There's carbamates and organophosphates, and the main difference between them is a property known as aging. And for organophosphates, they have something called a leaving group. And once they've been bound to the cholinesterase for a certain amount of time, that leaving group will break off, and the cholinesterase is permanently inhibited. The organophosphate is permanently bound to it. How long that takes depends on the agent. For some of the pesticides, it might be many hours or a day or two. For some of the military agents, it can be pretty short. Soman has an aging half-time of 4 minutes. Organophosphates are the only ones that age. Carbamates never age, so they are always potentially reversible. So in order to know what you're going to see clinically, you just have to know where acetylcholine lives in the body. And there's two basic types of acetylcholine receptors. There's the nicotinic, which are in the ganglia of both the sympathetic and the parasympathetic system, as well as in the neuromuscular junction. And then there's the muscarinic, which is the postganglionic neurotransmitter for the parasympathetic system and for sweat glands. Right? So you guys remember that, right? Nicotinic, ganglia, and neuromuscular junction, parasympathetic, and sweat glands for the muscarinic. So you guys know the mnemonic for muscarinic signs of cholinergic excess? Opposite. Sludge. All right, so what's sludge stand for? Everybody can tell us off at the end because it's a little redundancy there. So which of these kills you? You salivate to death, or lacrimate to death? Okay, good. So this is a really dramatic presentation that allows you to easily identify the toxidrome fluids pouring out of your orifice, but it's not the things that kill you. The things that kill you are your killer bees of bradycardia, bronchoconstriction, and bronchorrhea. These are the muscarinic effects on the heart and lungs. So you're drowning in your own secretions, and you get bradycardia. Those are the muscarinic things that can kill you. The nicotinic things can also kill you. So fasciculations, weakness, and paralysis, which includes your diaphragm and your accessory muscles of respiration. So obviously, if you can't breathe, that will also kill you. So let's take our generic cholinergic synapse and turn it into neuromuscular junction. You have blocked cholinesterase and excess acetylcholine in the synapse, and it binds to the motor end plate and causes depolarization, and you get contraction, but it's not organized contraction. It's not like an impulse coming down from the brain out through the spinal cord through a peripheral nerve and stimulating the whole muscle at once. It's kind of random depolarization on the motor end plate, and that contraction looks like fasciculations, that disorganized contraction. Ultimately, you keep stimulating the motor end plate, completely depolarize it, and it can't repolarize because you keep stimulating it, and you get flaccid paralysis. Does this sound like something that you're all familiar with? Succinylcholine, right? So it's depolarizing neuromuscular blockade. So one way to think about the nicotinic signs of cholinergic excess is it makes acetylcholine look like succinylcholine. So there's also effects of acetylcholine in the brain. You can get seizures, you can get various types of altered mental status, which I already said that's not a good term, and coma. And to make the diagnosis, it's entirely clinical. You can send cholinesterase levels. There's two types that are easily measured, plasma cholinesterase and red blood cell cholinesterase, and they correlate to some extent with what you're really interested in, which is neuronal cholinesterase, the cholinesterase that lives in the synapse. But this test is a send out. It takes a couple days to come back. So if you're waiting to treat your organophosphate poison patient for that level, the patient's going to die. So you need to recognize the signs and symptoms, and you just base your treatment on that. So the treatment, so normally for most ER lectures, always the treatment starts with A, B's, and C's, but here's something comes before A, B's, and C's. If somebody's externally contaminated with something that might get you sick, then they need to be decontaminated before you can safely take care of them. So if you have some kind of mass casualty scenario with some organophosphate, the person should be decontaminated first. Usually that'll happen at the scene. We know from the sarin attack in the Tokyo subway that a lot of people are going to come on their own, not through the ambulance. So those people are going to need to be decontaminated on site. And decontamination is basically take off your clothes and take a shower. That's most of the contamination is removed by removing the clothes, which includes glasses, jewelry, watches, all that stuff. And then the remainder, just copious irrigation with water. Then you can address A, B's, and C's, and whether or not somebody needs to be intubated is a bedside decision, or whether they're stable enough for you to be able to try your antidotes first. And our initial antidote is atropine. This is a Mark I kit. This is the old kit that was developed by the US military as a nerve agent antidote kit. Fitney also carries these now in So atropine, which is the small auto injector down there, we're not going to be using the auto injectors in the hospital. We'll be using the regular pharmaceutical atropine that's in a vial or in an ampule. But we're going to be using doses that are really different from the doses that we're familiar with for bradycardia. So it's not a half a milligram every 5 minutes up to 3. You're going to start with a milligram and using a double philosophy. So you're going to go 1, 2, 4, 8, 16, 32, really quickly getting to very high doses. And your endpoint is drying of pulmonary secretions. You should hear clear lung sounds. It doesn't matter if the patient gets tachycardic. What matters is that they can ventilate and oxygenate. And so it used to be in the pre-9/11 days that one pesticide patient could deplete an entire hospital supply of atropine. Now, if there were a mass casualty scenario, there's pushback into the antidote that are at strategic locations around the country. I think the New York one is JFK. And so if there was a mass casualty scenario, they could push large amounts of antidote to where it's needed. I should mention that for the military nerve agents, it looks like they may not need as much atropine as for pesticides. From the sarin attack in Japan, there were maybe, I think, 12 patients that wound up in the ICU after that attack, and none of them actually needed more than 10 milligrams of atropine. So they're more, the military agents tend to affect the cholinesterases that live in your neuromuscular junction more than your other synapses. So the other element of treatment is Pralidoxime. And Pralidoxime is a cholinesterase reactivator. So it basically kicks the organophosphate off of the cholinesterase and regenerates enzyme that can be effective. That only works up until the point that the enzyme has aged. If it's aged, then the oxime won't work anymore. So I have to mention that there is a little bit of controversy about oximes, particularly in the developing world, where first of all, where most of the pesticide poisonings happen, because people have access to them and people know that that's something that you can take if you want to kill yourself, whereas here people take the thing that's close, which is usually acetaminophen. So they have a lot of experience with these poisonings, and they don't like to use oxime because they're really expensive and they often can't afford them. And there's actually some evidence for an oxime-free approach to treating these patients. Now keep in mind, if you don't have the oxime, you're giving no treatment for the nicotinic effects, right? The atropine only treats the muscarinic effects. So if they have paralyzed muscles of respiration, it means they need to be intubated and on a ventilator, potentially for a prolonged period of time. Let me show you the evidence. So this is a paper by Edelston, and he's actually had a couple of papers that validated this data, but he's the first one to do a randomized controlled trial of oximes for organophosphate poisoning. And I'm going to cut to the most important figure from the paper. But in a randomized controlled trial with pretty good design, the saline group did much better in terms of risk of death than the group that got treated with oximes. And if you look at the forest plot, every subgroup, although they all cross the midline, seems like they did worse with the oximes. So the overall group doesn't even cross the midline and seems to have done better if you didn't get the antidote. Now, I have to tell you that if you ask Mike Edelston, he still uses oximes, and this is in a very different setting that we're treating these poisonings in. And you know, if you look, the group that most of these patients presented pretty late, over 4 hours post-ingestion, and there's a trend that maybe if they presented earlier, they might have done better. But I do want you to be aware that this controversy exists. For your board exam, the answer is still definitely oximes, because that's the standard in the US. Yes?
You know, I've treated it both ways. In the Philippines, when I worked there, we saw a lot of this, and we couldn't afford the oximes. Very rarely someone brought it as a present to us. So we just gave atropine, and sometimes you wind up giving it for weeks, the atropine.
Yeah, absolutely.
And it gets harder and harder to do it. You got to keep watching them, keep watching the bad ones, and they stay on a ventilator sometimes for weeks. I find that if you give the oxime, it not only they get better sooner, but you get away with, in my experience, using much less atropine.
Absolutely.
And it's just much easier to manage than after that day.
I agree, and I think that if you ask most toxicologists that they would advocate for using oximes if you have them available, but I do want to present a balance to you that there is this significant point of view among the people who take care of the bulk of these poisonings in the world that maybe you don't need them. But if I had a patient here at Kings County, I would definitely give them the Pralidoxime as well, just to be clear. Okay, in addition to the standard elements of treatment, there are some adjuncts that potentially may be beneficial. In animal models of animals that are poisoned by organophosphates that are optimally treated with atropine and oximes, diazepam has an independent benefit on mortality, probably through mitigating some of the central effects of the organophosphates. And then there's some adjuncts that just make sense. If one of the things that's going to kill you is muscarinic excess in the lungs, we have an anti-muscarinic that's designed to go straight to the lungs. Maybe it would decrease your total atropine supply requirement for these patients. So it's something that I would probably do in addition to doing the other stuff. It wouldn't be a substitute. All right, next case. 17-year-old girl was brought in by ambulance for altered mental status and slurred speech. She was last seen normal 2 hours before. She's got a history of major depression and is on toxicity. And her physical exam is significant for tachycardia and hyperthermia. And she's agitated, and she's speaking with this muffled cotton mouth breathe. I can't really do it well, but it's something like that. And her skin is warm, flushed, and dry. Her pupils are large and not reactive. And she has no bowel sounds. Somebody puts a Foley catheter in, and there's almost a liter of urine in the bladder. Okay, anticholinergic. Someone said tricyclic, and I'm going to address that now. EKG shows times TAC at 120, and normal QRS and QT, and no terminal 40 milliseconds right axis. So not tricyclic. But it is actually the appropriate first concern. When you see an anticholinergic, your first thought should be, could this be a tricyclic? And then once you rule that out, address the others. So physostigmine is administered, and several minutes later, her mental status and physical exam is completely normal. She says she took 50 tablets of Unisome. What's that? Sleep. Yeah, to sleep. So there's actually two different things that can be in Unisome. It can either be diphenhydramine, same as Benadryl, or it can be doxylamine, another anticholinergic antihistamine. If you knew it was doxylamine, you'd also check a UA because they can get atraumatic rhabdomyolysis if you take an overdose of doxylamine. All right, so there's a lot of things that are anticholinergic that are out there. Antihistamines, and in New York City, by far, the number one anticholinergic overdose that you're going to see is Benadryl. Antipsychotics, particularly the older ones, the butyrophenones like haloperidol, the phenothiazines like Thorazine, but some of the newer ones too. Olanzapine is pretty anticholinergic. Antidepressants, and here again, not the newer SSRIs and SNRIs, but the traditional tricyclic antidepressants. And of all of these are the most important ones to identify because of all of them, first of all, they're the only ones that are going to kill you. And so that's obviously important. And the treatment is completely different. So you're going to be addressing the EKG abnormalities by giving bicarbonate instead of the treatment with just physostigmine for the other anticholinergics. Some of the things that we use to dilate the eye are anticholinergic. There's a lot of anticholinergic plants out there, things like Atropa belladonna. This is the plant from which atropine is derived. This is Datura stramonium, also known as ginseng weed. And this goes throughout the continental US and is responsible for epidemics of pediatric anticholinergic poisoning. It produces these pods that are kind of spiny and they contain seeds. People ingest these seeds and make a tea or put it into a soup or something. And they basically can wind up having hallucinations and the full anti-muscarinic toxidrome, but the thing they're looking for is the hallucinations. So they may, it used to be they'd hear it through the grapevine, or they, hear it from the older kids that this is something you could do. Now they're more likely to find online that this is a way that they can hallucinate with something that grows probably right around their school. But maybe they didn't read the part where they can't pee for 2 days and kind of miserable. But this is a kind of classic board question. Epidemic of pediatric patients looking anti-muscarinic, then those patients are probably a ginseng weed case. So I talked about the military nerve agents. There's actually a military anticholinergic agent called BZ that the US developed as a humane weapon of war, an incapacitating agent. The idea is instead of killing the enemy, you make him hallucinate, it makes him ineffective in combat, and it takes a couple of his buddies out of action to try to take care of him. Supposedly it's all been decommissioned at this point, Iraq was supposed to have a similar, if not identical agent called Agent 13, but like a lot of the things that they were supposed to have, there hasn't been a lot of evidence since we went in there. So when I talked about the cholinergic toxidrome, we talked about the nicotinic effects and the muscarinic effects, but when we talk about the anticholinergic toxidrome, there's no anti-nicotinic part of it. It really should be called the anti-muscarinic toxidrome. So again, there's nothing in the ganglia, nothing in the sweat glands, sorry, nothing in the neuromuscular junction. It's basically anti-parasympathetic, anti-sweat glands. So you ready for your mnemonic now?
Now does it matter? How does the hair dry from?
Yeah, nobody remembers the whole thing because it's a terrible mnemonic. I don't know where it came from. But yeah, I don't know how this helps anyone to remember. For me, I think anti-parasympathetic, anti-sweat glands is about as easy as it gets. But so red as a beet, you get flushing. Hot as a hair, you get hyperthermia. Dry as a bone, you get dry mucous membranes, dry skin. Full as a flask, urinary retention. Blind as a bat, your pupils are dilated and can't constrict or accommodate. And mad as a hatter is the central delirium. My fellowship director, Lewis Nelson, used to say, just make everything a pepper. That's way easier. Sort of. I like mad as a hatter. Mad as a pepper is pretty good. Personally, I think anti-parasympathetic, anti-sweat glands is the easiest. All right, so to make the diagnosis, you recognize the signs and symptoms, put it